So as Eric mentioned, my name's Leech, Clinical Nutritionist and an Ayurvedic Herbalist, and I graduated from Endeavour, just like you guys will, and last year I did complete my honours with Dr. Steele and Dr. Swass. Now, I am at the MITS, as Eric mentioned, doing my PhD over at UTS, and this evening I'm going to be talking all about intestinal permeability and the diseases in which it's associated with, how to identify in clinical practice, and the most effective treatment options. A brief outline of the topics we shall be discussing, and as Eric mentioned just before, these are the 4 objectives I'd really like to portray to you this evening, is to understand the conditions associated with intestinal permeability, the risk factors, the clinical features, and how to go about treating it. Now firstly, intestinal permeability, it was first mentioned in the literature about 50 years ago, and naturopaths and the general public will generally refer to it as leaky gut. So to start off this evening, I want to ask you, if I was to ask you to search the literature to find the association between intestinal permeability and, let's say, chronic fatigue syndrome, what search term would you use? Would you use leaky gut? Would you use intestinal permeability? Okay, right? So let's have a little look at what the results would prove. So if we searched intestinal permeability and chronic fatigue syndrome in PubMed, you'd get a total of 7 results, okay? If you use lipopolysaccharides, which is a marker of intestinal permeability and chronic fatigue syndrome, you'd get 36. However, if you used every possible term to describe intestinal permeability, you'd get about 66 results. Why am I showing this to you? It's important to search the literature right when it comes to intestinal permeability. So a hypothetical comprehensive search term for searching the literature for intestinal permeability would look something like this, using all the key factors that may be mentioned within the published literature. Alright, so they're the terms that could describe intestinal permeability. But what is intestinal permeability? Right? Do we all understand what intestinal permeability is? We've mentioned the term leaky gut in a lot of lectures before. Intestinal permeability involves the loss of integrity within the small intestines. More precisely, it's when the tight junction proteins will actually separate or become disassembled within the intestines. So if you can imagine, my fists represent the intestinal cells of your small intestines. During intestinal permeability, they open up. The disassembling of the tight junction proteins. Now, zonulin. Zonulin is a protein. Now, zonulin is the only known physiological mediator discovered to date known to regulate intestinal permeability. So the release of zonulin can be triggered by Gluten, a particular protein found within gluten, and dysbiotic bacteria coming into contact with the enterocytes. This particular protein was discovered about in early 2000 by Dr. Bassano and his team over in Italy. However, naturopaths and nutritionists like ourselves have been treating this so-called leaky gut for much longer than that. You can ask me the question now, well, what is wrong with leaky gut? Well, basically, leaky gut will lead to an increased absorption of dietary antigens and lipopolysaccharides. This then goes on to cause interference with our immune system, stimulate inflammation, and lead to dysbiosis, all of which are the leading drivers to modern disease. Now, within the research community, there's a couple of questions that we're trying to answer at the moment. One of which is, does intestinal permeability cause the disease, or does the disease cause intestinal permeability? It's like the chicken or the egg scenario. What I can tell you 3 things. First of all, intestinal permeability precedes the clinical onset of type 1 diabetes, celiac disease, and Crohn's disease. That is, someone is diagnosed with intestinal permeability before they get the clinical diagnosis of these autoimmune conditions. Furthermore, that inducing intestinal permeability increases disease severity. Disease will get worse with a worse intestinal permeability. And lastly, if we correct intestinal permeability, this will actually reduce clinical signs and symptoms of the disease. My thoughts on this is basically without intestinal permeability, disease which are associated with intestinal permeability won't actually be able to progress and exacerbate. So intestinal permeability is a driver in the diseases in which it's associated with. There are numerous conditions known to be associated with intestinal permeability. In fact, it was about 40 years ago that it was first mentioned in the literature that intestinal permeability is associated with not only celiac disease, but it's the severity of celiac disease. Now, examples of these conditions can be anything from non-alcoholic fatty liver disease, type 1 diabetes, and so forth. So in the systematic review that we conducted last year, we proposed that 1 in 3 individuals will experience intestinal permeability in conditions which are associated with intestinal permeability. So put it in another perspective, over here we have a list of associated conditions, anything from ulcerative colitis, Crohn's disease, type 1 diabetes, liver cirrhosis, autism, and so forth. If you have a client coming into you and they have one of these known associated conditions, there's a 1 in 3 chance that they'll have intestinal permeability. Now, of all of these conditions, the literature suggests that intestinal permeability is strongly associated with both autoimmune conditions and liver-related conditions. Okay, our research in our review, we also suggest that disease severity and clinical symptoms will actually correlate with intestinal permeability, and that the severity of intestinal permeability appears to be exacerbated when there is dysbiosis, inflammation, and a glucose metabolism disorder such as diabetes. So it raises the question, if we correct dysbiosis, inflammation, and glucose metabolism, would that correspond with an improvement in intestinal permeability, and then onwards to the disease itself? Another research we did was we evaluated naturopaths, nutritionists, and Western herbal medicine practitioners who in clinical practice on an array of particular aspects regarding intestinal permeability. One of which was the group of conditions in which they associate with intestinal permeability. So from the survey participants, we showed that 100% of participants observed that intestinal permeability was associated with gastrointestinal related conditions. And then autoimmune disease, skin related, and so forth. At the very bottom, that's one I want you to pay attention to. Only 44% of the survey population actually acknowledged an association between intestinal permeability and liver-related conditions. However, the literature, there's an ample amount of evidence supporting that there is an association between liver-related conditions and intestinal permeability. However, clinicians in practice at the moment don't actually recognise that. So that there is a gap in our evidence-based practice, and clinicians already in practice should actually be educated on the association between the two. Furthermore, in our research, we also looked at individual conditions and which ones practitioners actually associate or observe an association with intestinal permeability. The highest ones, of course, food sensitivities, intestinal dysbiosis, IBS, non-celiac gluten sensitivity, and the list goes on. All right, so if we can take a zoom out from the individual clinical setting, we can look at intestinal permeability on a more global level. Unfortunately, there's not a lot of research looking at intestinal permeability in healthy individuals on a global level. However, the early research that we do have suggests that there isn't much of a difference between countries. However, there is a trend saying that intestinal permeability is higher in these subtropical areas. However, further research would be required to confirm that. Etiology of intestinal permeability. We still don't fully understand the full cause of intestinal permeability, but the current theory is that it involves genetic, environmental, and epigenetic factors. So remember I mentioned zonulin. I'm going to be mentioning zonulin a bit this evening. Any factor that is shown to contribute to intestinal permeability does so by stimulating the release of zonulin. So you can think of an example. You've got substance X. It could be anything. It goes on to cause an upregulation of zonulin, which then causes a disassembly of tight junction proteins within the small intestines, which then leads on to intestinal permeability. It's a cascade of events. You can have both indirect and direct causes of intestinal permeability, or drivers, might I say. This could be intestinal dysbiosis or inflammation, which can then lead on to intestinal permeability, or direct factors such as diet and medication. All right, risk factors for intestinal permeability. Now, intestinal permeability is a natural and normal response during pregnancy. It's there to translocate the microorganisms within the mother's gastrointestinal tract and immunological compounds to the unborn fetus. However, excessive pregnancies, more than 3, has been associated with an increased risk of intestinal permeability. So if you can combine a number of pregnancies and the improper diet, then disease may develop. Now, I see this quite often in my clinical practice. A client will sit down, generally female, because you need to be female to have pregnancies. And they will say, I developed X autoimmune disease, generally Hashimoto's, after my second or third child. And then you look at their diet and it's just piled up with gluten. We all know that correlation between Hashimoto's and gluten. Now, another risk factor for intestinal permeability is having a direct family member with an autoimmune disease, especially the inflammatory bowel disease, ulcerative colitis, Crohn's, and celiac disease. Now, this was an interesting one, autism. So individuals with autism, on average, 36% will have intestinal permeability. You compare that to their relatives, who have intestinal permeability 21%, and then healthy control only 5%. So if you have a direct family member with autism, then there is an increased risk of actually having intestinal permeability. One of the last ones, IBS, so irritable bowel syndrome. Now, it's been suggested that up to 80% of irritable bowel sufferers actually have irritable bowel disease, irritable bowel syndrome, due to SIBO, which is small intestinal bacteria overgrowth. Now, we can remember what were the 2 major factors that causes the upregulation of zonulin. It's gelatin, protein within gluten, and dysbiotic bacteria. So during SIBO, small intestinal bacteria overgrowth, there is an upregulation of dysbiotic bacteria within your small intestines, which can then lead on to intestinal permeability. Particular common environmental factors, first of which is diet. Now, I can't stress this enough. Modulating and changing the diet is the number one most important aspect that you can do to support someone, to support your client with intestinal permeability. Known factors to contribute to intestinal permeability include alcohol consumption, fructose, gluten, saturated fats, and arachidonic acid. I'm going to talk about these in a bit more in depth a little later. We've also got nutrient deficiencies, vitamin D, zinc, and glutamine. Medications, now antibiotics, that's a no-brainer. We know that antibiotics can actually disturb the natural flora of our intestines, leading to intestinal dysbiosis. Non-steroid anti-inflammatory NSAIDs. These are actually used in both cellular and clinical studies looking at intestinal permeability. So researchers will actually use NSAIDs to cause intestinal permeability in a given population to run tests. Lesser known environmental factors, first of which, acoustic stress. So that's loud noise. Roughly about the volume of a lawnmower has been suggested to actually aggravate inflammatory bowel disease and lead to an increased release of inflammatory cytokines. Acute psychological stress. So psychological stress leads to a cascade of events which can eventually lead to activating mast cells within the small intestines. Exercise. Do you think yoga or Bikram yoga or running could be contributing to intestinal permeability? All right, I'm going to leave that as a teaser. We'll come back to that. Glyphosate, first patented in America as an antibiotic, commonly found in pesticides and herbicides like Roundup, can actually contribute to dysbiosis. Now, I encourage you, if you want to know more about this, watch the documentary What's with Wheat by Cindy O'Meara, a Sunshine Coast nutritionist. Signs and symptoms of intestinal permeability. By far the most prevalent symptom of intestinal permeability is food sensitivities or intolerances. Even the practitioners that we surveyed, 97% observed that it had a high association to intestinal permeability. And we've shown in research that the severity of food sensitivities correspond with the degree of intestinal permeability. That's it. When you have a high degree of intestinal permeability, when the tight junction proteins are greater, then you'll have a greater number and severity of food sensitivities. Of course, you've got your gastrointestinal symptoms, anything from bloating, cramping, pain, constipation, diarrhea. And through the gut-skin axis, you've got things like acne and dermatitis. Genetics. So I mentioned before how if you've got a direct family member that has an inflammatory bowel disease, then you are at a greater risk of intestinal permeability. We still don't fully understand the exact genetics that predispose someone to intestinal permeability. We're working on it. But yeah, at the moment, if you do have a relative with inflammatory bowel disease, you are at a greater risk of intestinal permeability. SNPs, or genetic mutations, diamine oxidase. It's been proposed by a number of professionals in the area of epigenetics, such as Dr. Ben Lynch or MTHFR Australia. These professionals, they say, oh, it causes leaky gut. Now, for those who don't know, diamine oxidase is responsible for the breakdown of histamine. And in fact, 70% of histamine intolerances has been suggested to actually be caused by a lack of this enzyme. There's still limited research, so I'm not totally conclusive whether this SNP plays a role, but it's something to keep your eye on, especially when genetic testing is becoming more popular in clinical practice. Now you've got two factors here, alcohol and estrogen, both of which can be classified as environmental factors, but they can contribute to intestinal permeability on an epigenetic level. That is, that they can actually change and trigger the expression of tight junction proteins. So just remember that alcohol causes intestinal permeability through gene expression, because I have a treatment for you, alcoholics. Gluten, right. Who here in the room, we're not alcoholics, thinks that they have intestinal permeability? Raise your hand. Come on, got a few. We're not all perfect. Keep your hand risen, up high. Keep your hand risen. I want to see it. Do you still consume gluten? All right, we've got one up the back. My role is to convince you otherwise. All right, so gluten consumption directly causes an upregulation of zonulin, which then causes the tight junction proteins to disassemble, leading to intestinal permeability. Now, gluten causes intestinal permeability in everyone, regardless of the disease status or clinical symptoms. So this is where you ask me, oh, but Brad, I don't have, I'm talking to you at the back, I don't have any symptoms after eating gluten. What I say to that is it's only the severity that changes. So we all have intestinal permeability after being exposed to gluten, but it's the severity that changes. You can see here, severity at the very end. So when we expose individuals with active celiac disease, they have the highest severity degree of intestinal permeability, closely followed by gluten sensitivities, and then celiac disease in remission, and then healthy control. Right here's the cutoff point. So the cutoff point is, does someone have intestinal permeability, or does someone not have intestinal permeability? And so yes, gluten exposure contributes to intestinal permeability. Did I convince you? Not yet, okay. All right, so another fat. All right, so we mentioned before that gluten triggers the release. Gluten causes intestinal permeability, but gluten can also contribute to intestinal permeability indirectly through inflammation. Now, when gluten comes into contact with the enterocytes of the small intestines, it causes a release of interleukin-8, an inflammatory cytokine. Now, the release of inflammatory cytokines, as you all know, after being exposed to gluten, is governed by the cellular content of arachidonic acid. Arachidonic acid, right. So there's three major fatty acids. You've got your EPA, DHA, which are anti-inflammatory fats. These are found in fish or made in your body from flax seeds and chia seeds and so forth. The other fatty acid, arachidonic acid, which is pro-inflammatory, found in the diet in eggs, dairy, and meat. Now these fatty acids will actually determine what fatty acids, like when you consume these fatty acids in the diet, will determine the ratio found within each and every one of your cellular membranes. So when a diet is higher in arachidonic acid, as evident in image A, we can see that a trigger, let's say gluten, comes along, will cause a greater release of inflammatory cytokines. So higher dietary consumption of arachidonic acid leads to a greater inflammatory response after being exposed to an inflammatory trigger. Okay, exercise. This one's very interesting. This one really got me in my clinical practice. Prolonged exercise increases your core temperature to about 39 degrees. However, your intestinal temperature raises to about 41 degrees. Why? It's because when you're running, like so, all the blood leaves your intestines and goes to your outer arms and legs, used for running, of course. Thereby, you're unable to cool down the intestines because blood is used as a cooling mechanism, a homeostatic mechanism. Now, it's been shown that a 2-degree increase in intestinal temperature increases intestinal permeability by 3-fold. That's huge. Now, looking at the different intensity of exercise, if you were to run 60 minutes at 70% of your best in 30-degree heat, would cause intestinal permeability. If you were to run just for 20 minutes at 80% of your best, it would cause intestinal permeability. So it doesn't actually appear to be the time, which is the biggest factor, but more so the intensity. So this particular study showed that 2 hours of running at 60% of your best in both 30-degree heat and 22-degree heat does not cause intestinal permeability. All right, so I've categorized these into 3 groups. We've now moved on to identifying intestinal permeability in clinical practice. First of which are the validated Lactulose, Mannitol urinary test and the Serum Zonulin. We're going to discuss these in depth a little later. We've also got the traditional and the naturopathic ways, Aetiology, look into people's eyes, and HemoView, live blood analysis. Other kind of suggestive pathology include your comprehensive digestive stool analysis, a food intolerance IgG test, and even patients' signs, symptoms, and medical history. Now, from our research, we showed that the lactulose mannitol test was the most frequently used method to identify intestinal permeability available to clinicians, followed by your comprehensive digestive stool analysis, zonulin, HemoView, Aetiology, and so forth. However, we also showed that almost 60% of surveyed population, that's naturopaths, nutritionists, just like yourselves, going to be, they would never or rarely test. Now that there does not uphold my level of evidence-based practice. We promote ourselves as following evidence-based practice, yet we do not test for intestinal permeability. Why? The biggest response was the cost. It costs to do these functional testings. The lactulose mannitol test, the serum zonulin, you're looking at about $120. You look at how much that money could be used to actually treat the client rather than just testing. We also showed that patients' signs and symptoms were the main reason that practitioners will suspect intestinal permeability. That's the main indicator that we use as clinicians to identify intestinal permeability versus your validated method. Now, if it's not validated, then we don't know if it's 100% accurate. Therefore, we concluded that the results of our study highlight the potential value for the development, the validation of a screening tool to identify intestinal permeability based on patients' signs, symptoms, and medical history. So I've decided to undertake this mammoth task as my PhD, and if successful, you guys will all have a free validated tool that you can use in clinical practice to save your clients money and to identify intestinal permeability and suggest treatment options and even further testing. So fingers crossed, we've got a couple of years yet. All right, so looking at the validated methods that we have already, we've got the Lactulose Mannitol test. So in a healthy gut, under normal intestinal permeability, mannitol, which is a monosaccharide sugar, is readily absorbed, while lactulose, a disaccharide, remains within the intestines. You can see in this image, the smaller dot is the mannitol, it's able to permeate, where the larger molecule, the disaccharide, lactulose, is just shunned away. Now, during intestinal permeability, the ratio of lactulose to mannitol is increased. That is, lactulose is actually able to permeate through the mucosa of the intestinal wall and enter the urine. And so that's the foundations and the basis of how this urinary test is used to identify intestinal permeability. Now, this would be a report that you get from Nutripath, a functional pathology company. The lactulose mannitol ratio has got the highest diagnostic value to identify intestinal permeability. So within clinical practice, this number right here, this is what you want to be looking at. This is the most researched marker of intestinal permeability. However, here we have a pile of conditions looking at the severity of their intestinal permeability based on their lactulose mannitol ratio. So in the light blue, we have what the mean average of the healthy population was, and in the dark blue, the disease stated, the disease mean average of the lactulose mannitol. Right here, this is the cutoff point. Now remember, a cutoff point is to determine whether someone has or hasn't got intestinal permeability. So according to, I'm not picking on Nutripath here, but according to Nutripath's cutoff level, these conditions here wouldn't be associated with intestinal permeability, right? But what if they had intestinal permeability? You have clients not getting optimal treatment care because the cutoff value for this particular company is too high. So we're in the midst of determining a more accurate cutoff point. So our current hypothesis is that around that 20 mark is an ideal cutoff point for a healthy population. Compared that to 35 in Nutripath. We're still working on the research, so watch this space. It's going to get very interesting. Okay, the other validated method to identify intestinal permeability in clinical practice is, of course, your serum zonulin. Now, as mentioned earlier, serum zonulin, or zonulin itself, is the only physiological mediator discovered today known to regulate intestinal permeability. Your body will actually produce zonulin in your intestines, liver, heart, lungs, and adipose tissue. Okay, so just bear in mind adipose tissue. This image here, this is the cascade of events that occur from zonulin stimulating to tight junction proteins opening. It's a very complicated cascade of events which we won't discuss. Now, it's been shown that serum zonulin is an accurate, it corresponds, might I say, with lactulose mannitol tests as an accurate marker of intestinal permeability. However, recent research from 2017 suggests that serum zonulin is actually influenced by a number of factors, excessive adipose tissue, blood pressure, fasting blood glucose, and weight, and hyperlipidemia. So if we're comparing the lactulose mannitol test versus zonulin, the zonulin, they're about the same price. However, the zonulin test, being that you can use it in a routine blood pathology, it's more convenient for the patient because with the Lactulose Mannitol test, you've got to be collecting your urine for about 5 hours, and that can be a bit of a pain. However, if someone has like a metabolic syndrome-like status, excessive adipose tissue, like these conditions that we described right here, then it can actually cause a false positive. So what is my clinical recommendation? Yes, if you want to use Serum Zonulin to evaluate intestinal permeability in your clients, great. Make sure that these factors aren't going to influence the reading, or you take them into account. Oh, treatment. All right, so when it comes to the treatment of intestinal permeability, using both lifestyle and dietary modifications, and including a few supplements, will be beneficial. I will stress this now, that if we just treat the tight junction proteins of the small intestines, it is significantly insufficient and optimal results will not be achieved. That is, if we just target the tight junction proteins for intestinal permeability rather than the whole person, the whole patient, you're not going to get the results that you want to see. I'll also state that correcting and amending intestinal permeability isn't the holy grail. It's not going to fix everything your client presents with. However, if your client presents with a condition associated with intestinal permeability, or they have intestinal permeability, then yes, the research states that there will be a clinical and significant improvement. As mentioned before, amending dysbiosis, inflammation, and glucose metabolism disorders may actually support intestinal permeability. So taking those into account when we're developing a treatment plan for our clients. 5 major factors. It's important to actually evaluate your client to determine which factor needs to be addressed. So for an example, I mentioned earlier that excessive alcohol and estrogen, such as, let's say, estrogen dominance, can actually cause an epigenetic effect on the tight junction proteins. So identifying that and then treating that aspect of intestinal permeability is essential. All right, this is where you ask me, all right, so how long do I prescribe glutamine for? How long will it take before my clients will actually observe improvement after I treat their intestinal permeability? Sadly, I can't tell you that. The research is very limited surrounding that area. But what I can tell you is that the treatment of intestinal permeability is multifactorial, with both environmental and genetic factors involved in the development of intestinal permeability. Thereby can be a lengthy process. So from the participants that we surveyed, they observed that it took a minimum of 3 months of treatment to resolve intestinal permeability, with majority, saying almost 50%, observed it takes 6 months. So on average, you're looking between 3 to 6 months of gut repair work to modulate and to correct intestinal permeability based on what other practitioners are already doing in clinical practice. All right, so before we look at the individual treatments, from the study that we conducted last year, these are what the most frequently used dietary, lifestyle, and supplements used by graduates, used by naturopaths and nutritionists to treat intestinal permeability. First of which, of course, reduction of alcohol, followed closely by zinc. Now, gluten, reducing gluten-containing foods was also mentioned. However, it wasn't quite as high as I would have liked it, but it is still there. Multi-strain probiotics, followed by vitamin D, actually reducing dairy consumption was mentioned, followed by reviewing antibiotics, then prescribing glutamine, turmeric, and so forth. But if we look first at the lifestyle factors that you can implement in your clinical practice for treating intestinal permeability, we mentioned earlier acoustic stress. So let's have a think. Who would be most vulnerable or most at risk of acoustic stress-induced intestinal permeability? That's a mouthful. I'm guessing it's going to be someone who's between 18 and 25, They spend 2 to 3 nights in a dark box with flashing lights, loud music. These individuals that go out clubbing and so forth, they're exposed to loud noise. So if anyone's looking for a job once they graduate with a bachelor degree, head down to King's Cross Station, hand out earplugs. Mate, you'll make a fortune. Just educate everyone on safe earness. Safe ear practices. But no, in all seriousness, if a client presents to you, and it does happen when they're young, a young 25-year-old who has been diagnosed with inflammatory bowel disease or celiac disease, recommending them to wear earplugs when they're exposed to loud noise could significantly support their treatment plan. Vagus nerve stimulation. Have we all heard of vagus nerve stimulation? Do we have any MST practitioners in the room? Oh, where are they? So early research suggests that stimulating the vagus nerve actually modulates tight junction proteins and reduces inflammation. So we know that the vagus nerve starts up here and kind of cascades all the way down over our digestive system. Now MST, for those of you who are seeing clients at the moment, speak with a MST practitioner up in clinic about what they can do to stimulate the vagus nerve. Okay, they can actually put electrodes in the ear which stimulates the vagus nerve. If we can stimulate that, tight junction proteins. For the clients, bitter foods such as rocket, stimulating the bitter receptors in the vagus nerve can support with intestinal permeability treatment. Although the research is very vast, is very little, singing, going from a high note to a deep note, or rubbing your neck like so, or even chanting Om, have all been suggested to stimulate the vagus nerve, thereby reducing inflammation and tight junctions. All right, exercise. So from our research, we showed that the practitioners who did not recommend a reduction of intense exercise within the management of intestinal permeability observed that it actually took a longer period of time to resolve intestinal permeability. So in other words, practitioners over here that didn't talk to their clients about reducing their intense exercise while supporting gut health, it actually took them longer to see intestinal permeability fixed. So we can raise the question, what is the treatment recommendation? No more than 2 hours of exercise at 60% of your best during the gut repair program of 3 to 6 months. It's a good SMART goal, SMART recommendation that you can give to your clients. However, there will be clients who are either athletes or want to keep on partaking in intense exercise, and there are a number of treatments that are available for them. Before I start, I want to mention I'm not affiliated or associated with any supplement company. I'm just stating the research. So you've got Ultrabiotic 45, Bioceuticals. They did a particular study where participants took 1 capsule with breakfast for 4 weeks, and they actually observed that the participants could actually increase the runtime until they got fatigue in the heat. There was a reduction in intestinal permeability and gastrointestinal symptoms. Right here we have a probiotic which has got evidence to support its use in intestinal permeability. There were numerous other probiotics and particular strains shown to support intestinal permeability, but they're not available in Australia, so I didn't include them because there's no point giving you something that you can't actually use in practice just yet. Zinc's another one. Only at 8.34 milligrams elemental zinc was shown that after 2 weeks reduced exercise-induced intestinal permeability by 70%. And glutamine, of course, the intestine's energy source, based on a number of weights, roughly you're looking about that 10 gram mark. 2 hours before exercise actually reduced heat-induced intestinal permeability. Looking at particular dietary studies, first we've got inulin-enriched pasta. Having inulin within your pasta was observed to actually reduce intestinal permeability. But what was interesting about this paper was the pasta was made on gluten. You all know my feelings on gluten. I don't like it. So if we actually add inulin to gluten-containing foods, does that mean we can eat gluten? No, probably not. You look at this study. It was published in Italy. We all know the Mediterranean paradox, where you can go over to Italy, eat all the pizza and pasta you like, you're not going to feel sick. The wheat, the processing behind the wheat, it is different in Italy. Can we take this information and place it into clinical practice in Australia? I don't think so. I mean, it is worth noting, increasing inulin-rich foods, sure, but will it be as effective? I doubt it. Oligofructose, this is another one. 21 grams a day divided into 3 doses. Significantly reduced intestinal permeability after 12 weeks. So what does this look like from a clinical perspective? You've got, these are both fructans, okay? Naturally high fructan foods, you've got leeks, asparagus, onions, bananas, artichokes, including these particular foods in someone's diet will support with intestinal permeability. You've got your oligofructose, which is more of a simple sugar, which will be fermented quite earlier, versus inulin, which is a more complex sugar, which will reach the left side of the intestines. Can anyone think of one particular condition where you wouldn't prescribe this? SIBO. So this is a warning. Because SIBO and intestinal permeability are so closely linked, it is, this is a huge warning right here. If your client presents with any signs or symptoms that there could be SIBO, then recommending, increase your fructans is going to make their symptoms worse, and they're not going to like you. So making sure that you rule out any evidence of SIBO or even IBS before recommending an increased consumption of fructans would be recommended. Another dietary study looked at resistant starch, about 10 grams a day, showed that there was a 25% reduction in endotoxins, which is a marker for intestinal permeability. This particular study used a corn-derived product for resistant starch. I'm not a fan of that. But there are other high resistant starch-rich foods which you can include for your clients. My favorite is cooked and cooled sweet potato. So when you actually cool a starchy food like sweet potato, it actually increases the content of resistant starch. And so it goes the other way around. If you cook things, like if you cook your oats, the resistant starch content will actually reduce. Fats. Who here likes fats? I love fats. Who here likes coconut oil? Yeah, that everywhere. We've known for some time that fats contribute to intestinal permeability. However, we didn't know the amounts or the types of fats which were the culprits for intestinal permeability. This particular study showed that there was no difference between getting 20 to 35% of your energy intake from fats. So that makes sense. If you get 35% of your energy intake from fats, you won't get intestinal permeability. If you get 20% from fat, you won't get intestinal permeability. However, they looked at different types of fats. Unfortunately, guys, saturated fat from coconut at 16 grams was shown to cause intestinal permeability. Now you can reverse that, look at that on another level. 500 milligrams of fish oil actually reduced intestinal permeability in the short stands. So saturated fat, 16 grams. That's not a lot. That's what, a tablespoon and a half? I use that on a daily basis in each meal. Coconut oil is about 95% saturated fat. So during a intestinal permeability or leaky gut treatment protocol, reducing saturated fat may actually be necessary. The other one was arachidonic acid. Now, one particular researcher, Adams, 1999, I think, proposed that 90 milligrams per day of arachidonic acid was the upper limit for an anti-inflammatory diet. So we've all heard, prescribe a Mediterranean diet or prescribe an anti-inflammatory diet. 90 milligrams of arachidonic acid is classified as an anti-inflammatory diet. So we've all heard of calorie counting. You now have arachidonic acid counting. So I want you guys to all count the milligrams of arachidonic acid in your diet and all get really stressed. I can see it on your face. You don't want to do that. Don't worry, I've done the hard work for you. So when I was down here at the Endeavour a couple of years ago, 2015, with Eric and Brad, we calculated that an anti-inflammatory diet based on this particular figure would account to about 150 grams of animal-based products a day, excluding fish, which is on average the weight of your cell phone. So a mobile phone weighs anywhere between 130 grams to 170 grams. So using that as a visual illustration to your clients, saying do not consume more than the weight of your phone of animal-based products, excluding fish, per day, will be classed as anti-inflammatory and then thereby supports intestinal permeability. So these particular recommendations: reduce saturated fat, reduce arachidonic acid. As I just said, here are a number of foods very high in saturated fats, ghee, fatty cuts of meat, and so forth. I will kind of, put another disclaimer here. Saturated fats are not bad. They're great. They taste great as well. Great for the brain health, cardiovascular health, immunity, and the nervous system. So in no way am I saying remove saturated fat from your diet. I'm saying if you've got a client with severe intestinal permeability, removing saturated fat for a short period of time while modulating tight junction proteins, the environment within the gut, is essential. Lorazepam, a particular pharmaceutical agent. Okay, I know we are naturopaths and nutritionists in the room, but it is important to have an understanding of the pharmaceutical agents which are coming, which will become available to our clients. Now, lorazepam can actually regulate tight junction proteins and temporarily reduce intestinal permeability. Now, I mentioned temporarily because it's got a half-life of about 2 to 3 hours. So this is the pharmaceutical's way of continuing the dosage. So basically, you need to take this pharmaceutical agent every 2 to 3 hours for it to be effective. It is in phase 3 clinical trials. So you are looking at another 5 to 10 years before this pharmaceutical agent will reach Australia, but it is worth noting. Particular treatments that you could use in your clinical practice: Saccharomyces boulardii, SB, at 200 milligrams 3 times a day for 3 months in Crohn's disease patients who were in remission, showed a reduction of intestinal permeability. Vitamin D, 2,000 IUs of vitamin D for 3 months in similar population, reduced intestinal permeability. But what was interesting was this 25-hydroxy vitamin D. Individuals where their levels were higher than 75 had a significant lower inflammation status and a reduction in intestinal permeability. So you can almost use this as a ballpark figure within clinical practice. Your clients come to you, they say, hey, my vitamin D is at 50. You're like, all right, that gives me justification to actually increase it because the research suggests it. My favorite probiotic, anisetum. That's an amino acid. E. coli Nestle 1917. First discovered in 1917 in World War I in actual Germans' soldiers' intestines. It's very interesting. They actually theorized that it got into the Germans' intestines through a pig. Germans like their sausages. What's interesting about this particular probiotic is that it actually has the ability to colonize the gut. Not many probiotics have that effect. And also, it works on tight junction proteins on an epigenetic level. So if someone was either estrogen dominance or an alcoholic who had intestinal permeability due to the expression of the genes in the tight junction proteins, this particular probiotic has been suggested to actually correct that. Now, there isn't any direct research looking at this particular probiotic and intestinal permeability, but this study, this was very interesting. 200 milligrams for 12 months in patients with ulcerative colitis was shown to maintain remission equivalent to the gold standard pharmaceutical drug. E. coli Nestle 1917, as effective as pharmaceutical agents to maintain remission in ulcerative colitis. That's huge, mind-blowing. The other one down here was looking at improvement in patient-reported outcomes in IBS patients. I included this one because the results weren't significant until 10 and 11 weeks. It takes time. It takes time to correct intestinal permeability. So if you've got clients who are, 2 weeks afterwards, why do I still have intestinal permeability? It takes time. And it's important to look at the individual as a whole, not just pathology readings. Treat the whole rather than an isolated condition. Before I finish up, I would like to recognise the co-authors I've had on the papers I've already published, and then the numerous other supervisors, including Eric, that I've had over the years. So that does conclude my talk. Do we have any questions?